Next, let's talk about oxygen content in the blood. As you know, oxygen in blood is either bound to hemoglobin or dissolved in serum. Now, where is more oxygen carried? Bound to hemoglobin. Normally, 1 gram of hemoglobin binds about 1.34 milliliters of oxygen. Now, assuming a normal concentration of hemoglobin about 15, how much oxygen is bound to hemoglobin? Well, the answer would be about 20.1 milliliters. It's no surprise that the absolute oxygen content of arterial blood decreases as hemoglobin falls. You're losing your major carrier. However, you won't be able to tell that from the O2 saturation and arterial PO2, which can remain high. So what's a lung disease that was just mentioned that can decrease arterial PO2? Remember, chronic lung diseases like pulmonary fibrosis and emphysema can limit diffusion of oxygen and decrease arterial PO2. Bonus question. What can lower venous PO2 even if you have a normal arterial PO2? The answer is exercise. We'll talk a bit more about exercise at the end of this section. Let's work through this table together. Do you recall from the hematology section what polycythemia is? That's right, high hemoglobin levels due to red blood cell proliferation. Let's look at anemia and polycythemia first. How does the hemoglobin concentration change in anemia? Well, the actual definition of anemia is a decrease in red blood cell mass, which indirectly translates to a decrease in hemoglobin because hemoglobin is essentially what makes up the red blood cell mass. So in anemia, the hemoglobin concentration decreases. What about the hemoglobin concentration in polycythemia? In this condition, the hemoglobin level will be increased because, again, this is a disorder of excess red blood cell proliferation, and thus an excess production of hemoglobin. Now, staying with these two diseases, is the hemoglobin molecule itself affected? Well, no. In both anemia and polycythemia, the hemoglobin molecule itself is still totally functional and thus can still bind oxygen with the same affinity. There is just too little or too much hemoglobin present. So the percent oxygen saturation of hemoglobin will be normal. What about dissolved oxygen? Well, this is also normal since nothing in the serum has changed. And what about total oxygen content? Well, this will follow the same trend as hemoglobin concentration. In anemia, there simply just isn't enough hemoglobin present. This will lead to a decreased overall oxygen content. In polycythemia, the oxygen content will be increased because of red blood cell proliferation. What is different about carbon monoxide poisoning? Well, the hemoglobin itself is directly modified, so as we discussed, less oxygen actually binds each hemoglobin molecule. So what do you suppose happens to the total oxygen content? Well, it'll decrease. As we know, the carbon monoxide molecule takes up almost half of the oxygen binding sites on hemoglobin, so the hemoglobin molecules will all be less saturated with oxygen. However, in contrast to both anemia and polycythemia, there's still a normal amount of hemoglobin present. And again, because there's no effect on the plasma itself, there will be normal dissolved oxygen. Alright, good work. The oxygen and carbon dioxide contents of blood each have different effects on pulmonary and systemic circulation. Now this is an important concept to understand as it'll help you reason through situations where you may not have an immediate answer. Let's look at oxygen. A decrease in alveolar PO2 shunts blood away from less ventilated regions of the lung. This makes sense, right? Because it conserves energy by only circulating blood to areas with oxygen. But too much of a good thing can lead to pulmonary hypertension, which we'll discuss later in the pathology section. Another important concept to understand is when and how gas exchange is limited by either diffusion or perfusion. What's normally the limiting factor in gas exchange? Diffusion or perfusion? In healthy individuals, gas exchange is limited by perfusion. So what does perfusion limited mean? Here, gas equilibrates early along the length of the capillary. You can only get more oxygen into the blood by increasing the blood flow. Normally, oxygen, CO2, and nitrous oxide are perfusion limited. This is represented here, where you can see that the pressure of a given gas in the blood and in the alveolar air reach an equilibrium quickly, and no further gas exchange occurs while that same blood is in the pulmonary capillary. Contrast this with a molecule that's diffusion limited like carbon monoxide. The release of carbon monoxide from the blood is slow and dependent upon the amount of time it has to work its way out of the blood and into the alveoli. Now, what governs diffusion? Take a look at this equation. A is the area, T is the thickness, and this whole term is the difference in partial pressures. Now, for carbon monoxide, blood is not in the pulmonary capillaries long enough to reach equilibrium with the alveolar air. So when else does gas exchange behave this way? Carbon monoxide, obviously, and with oxygen in pathological states in which the gas either has a smaller surface area to diffuse across, such as in emphysema, or has a thicker membrane to diffuse across, such as with pulmonary fibrosis. You can see the same concepts here with oxygen. In exercise, the equilibrium occurs late along the length of the pulmonary capillary. So what's going on here? The heart is pumping and the velocity of blood is increased through the capillary bed, so there is less time for the oxygen to equilibrate. We're now going to discuss pulmonary vascular resistance. The key here is to understand the relationships among resistance, pressure, and flow. Now, does this concept sound familiar? Well, this is pretty much the resistance, pressure, and flow fact discussed in the cardiovascular physiology section, so feel free to reference that section in order to recognize the similarities. Again, it's not necessary to memorize these equations, but you do have to understand the relationships. Resistance equals the pressure gradient divided by the flow. In this case, R is the pulmonary vascular resistance. The pressure gradient, or delta P, is the difference in pressure between the pulmonary artery and the left atrium, and Q, or flow, is the cardiac output. Pulmonary vascular resistance is directly proportional to viscosity, which is represented here by the Greek letter ETA, and inversely proportional to the radius to the fourth power. This means that the radius is the most important contributing factor to resistance. The main point you want to keep in mind is that when blood is viscous and thick, for example in polycythemia vera, there will be an increased vascular resistance because the viscosity and resistance are proportional. However, it's the radius that carries the most weight in this equation. Increasing the radius can overcome an increase in blood viscosity. Flash quiz. On which aspect of circulation is pulmonary vascular resistance most dependent? The radius. It's raised to the fourth power in the denominator. The alveolar gas equation is used to calculate the alveolar arterial gradient, or the AA gradient. This is useful when trying to figure out the cause of hypoxemia, which we'll discuss next. PA is the alveolar oxygen partial pressure. PI is the partial pressure of oxygen in inspired air, and PaCO2 is the carbon dioxide in the arteries. R is the respiratory quotient, or 0.8. Ultimately, you can estimate PaO2 by knowing that PaCO2 from the arterial blood gas. So what's the normal PaO2 for a healthy adult at sea level? Well, the normal PaCO2 is about 40. So 40 divided by 0.8 gives you about 50. And finally, 150 minus 50 is 100. Meaning that a PaO2 of 100 is normal for a healthy adult at sea level. Now what's the bottom line? If you see an AA gradient greater than 15 millimeters of mercury with hypoxemia, you should be thinking about some sort of right-to-left shunt, VQ mismatch, or a diffusion limitation problem as we just discussed. These situations describe blood flow through the pulmonary vascular system that does not end up getting oxygenated. Very similar to a cardiac shunt secondary to a septal defect, blood is being sent into the systemic circulation without as much oxygen to be carried to peripheral tissues. Flash quiz. What disease states cause diffusion limitation? Emphysema and cystic fibrosis. Emphysema decreases surface area, and cystic fibrosis increases the thickness of the membrane. This is a useful framework for understanding the various scenarios in which not enough oxygen gets to the tissues. There are three specific scenarios you need to know about: hypoxemia, hypoxia, and ischemia. First, what's hypoxemia? Hypoxemia occurs when the partial pressure of arterial oxygen is decreased. That is, the oxygen content in the aorta is less than normal. It can be caused by things that decrease the amount of oxygen that enters the lungs with a normal AA gradient, such as high altitude or alveolar hypoventilation, or by things that prevent the oxygen in the lungs from entering the blood, i.e. a high AA gradient such as we discussed earlier, VQ mismatch, impaired diffusion, or a right-to-left shunt. Now speaking specifically about a right-to-left shunt, what could that include? Well, it could be anatomic, like tetralogy of Fallot with a VSD, where low oxygen content blood goes out through the aorta. Or physiologic, like pulmonary edema. In pulmonary edema, blood is flowing through the lungs, but all the edema in the alveoli block gas exchange, so blood returns to the left side of the heart without getting oxygenated. So now that we know what hypoxemia is, what about hypoxia? Hypoxia is the condition in which there is a decreased oxygen delivery to tissues, which can result from hypoxemia that we just discussed, or from other factors such as decreased cardiac output or carbon monoxide poisoning. So here's a question for you. What's the most common cause of decreased oxygen content in the blood in the setting of a normal oxygen saturation? The answer would be anemia. This again is because anemia is not a problem of oxygen binding. The hemoglobin molecules are still completely functional. It's a problem of hemoglobin production. There simply just isn't enough hemoglobin around. And what's the most common cause of anemia? Iron deficiency anemia, most likely secondary to blood loss. In addition to carbon monoxide poisoning, we should also add methemoglobinemia here as well. As you recall, it causes a functional anemia because the methemoglobin molecule does not bind oxygen as well as regular hemoglobin. Finally, ischemia is caused by a loss of blood flow to a particular tissue or organ, and thus the absence of oxygen delivery. This can be caused by something that impedes blood flow, such as an embolus, clot, or atherosclerotic plaque. Atherosclerosis-related ischemia can lead to clinical coronary artery disease, which is the #1 cause of death in both men and women in the United States. The progression of atherosclerosis and all of its pathologic changes in the human body will be covered in your cardiology sections. Ischemia can also be caused by decreased venous drainage. Because if blood can't exit a capillary bed, then no blood can enter it either.